Welcome to the NEI podcast. In today's episode, we're coming to you from the 2023 NEI Congress in Colorado Springs, Colorado. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Hi, my name is Dr. Tim Wilens, and I will be answering your questions about my presentation, Double Trouble, Diagnosis and Pharmacotherapy of ADHD and Juvenile Bipolar Disorder. So we're going to start with the questions. Can we diagnose bipolar disorder at the age of 6? Or what age can we think of diagnosing bipolar disorder? You know, the studies actually show that bipolar disorder onset in over 50% of even adult cases starts in childhood. And if you look, there's a small group that actually have the onset of their bipolarity in preschool years. We've actually published on this area. And probably somewhere in the age of 4 to 5, you can start to make a diagnosis of bipolar disorder. Some of the data from diagnosing it that early tends to show that if they have sort of the prototypic symptoms of bipolar disorder that you see, and often in that age group, it's just ferocious rage attacks, problems sleeping, not tired, real agitated. And also parents will tell you a lot of mood swings, and the kids will go get somber and depressed and then will become sort of high energy, really activated, et cetera, or the mixed symptoms. But if you have that constellation of symptoms, you can have it in preschool years. And by the way, the treatment is going to be very similar to school-age kids who have bipolar disorder. Could the increased rate of ADHD in childhood bipolar disorder be a lack of maturity, actual ADHD, and emotional lability, common with ADHD and not bipolar disorder? What we think about is that with bipolar disorder, when we looked at those kids who had bipolar and ADHD, and we looked at the first degree relatives, what we found was high rates of ADHD. And when we looked at the other sort of indices of ADHD, we saw those same indices. Finally, if you did brain scans on individuals who have bipolar and ADHD, you see the prototypic brain scan of somebody who has bipolar, more in the emotional regulation areas, the limbic areas, and then you would see also the prototypic findings in ADHD, frontal cortical, and those kinds of areas. But you see both of them at the same time. The question saying, could it be lack of maturity and just the actual ADHD and emotional ability? Yes, but if they have the criteria for bipolar disorder, it is bipolar disorder. And when we track those individuals who have ADHD and bipolar over time, 2 years, 4 years, 5 years, and out to 10 years, guess what? They have classic bipolar disorder in later adolescence and young adulthood. So let's go to the next question. Are there any specific subtypes or presentations of ADHD that are more commonly associated with juvenile bipolar disorder? If so, how can this knowledge guide treatment decisions? That's really a great question. And in fact, those individuals who have more of what we call the combined subtype ADHD, that is, you have the symptoms of inattention and distractibility as well as hyperactivity and impulsivity. If you have those classic combined subtypes, what we think is you have more symptoms of ADHD, typically a more severe ADHD, and that's the ADHD that's most commonly associated with bipolar. I have to say, it's an intriguing question I haven't thought about in terms of inattentive ADHD, but you typically don't see a lot of bipolarity develop out of individuals who have just the inattentive subtype of ADHD. And how does this affect treatment? It's probably not going to, because you're still going to be treating the ADHD and you're going to be treating the bipolar disorder. But it's a great question in terms of thinking about the presentation of ADHD and who's at biggest risk for bipolar. Let's go on to our next question, which is, what screening tool do you recommend for bipolar disorder for kids under the age of 14? And there's a number of different sort of screens. One of them is use of the child behavior checklist, aggression, attention, and anxiety. And that AAA score, if it's above 180 and certainly above 210, it's indicative of kids who have bipolar disorder. Other screening instruments you can use is you can use a mania rating scale to identify the manic symptoms. And why do we care about the manic symptoms? It's because the manic symptoms are what gives you the diagnosis of bipolar disorder. Remember, it's not the depression, it's the mania. And so if you have manic symptoms for half the day for a week with impairment, then you're dealing with bipolar disorder because of the mania. So using the Young Mania Rating Scale or any of the mania rating scales that are available, that would be sufficient. And finally, the DSM criteria with an understanding that they have to be developmentally tuned. Can trauma cause bipolar disorder? So severe trauma can lead to a lot of dysregulation, and it becomes important to try to understand if the dysregulation is bipolar disorder. Again, family history bipolar disorder. Does the individual have neuropsychological deficits? Also, does the individual have cyclicity to their dysregulation? Do they have the manic symptoms like we were just talking about? Do they actually have classic mania? And if the answer is yes to all of those, then you could say they have bipolar disorder and they had a severe trauma that may have sort of triggered that. Now, having said that, I want to say that we had, in a number of studies we've done looking at ADHD, at bipolar disorder, we find that, yes, there is a subgroup that have traumatic events and post-traumatic-like symptoms, but in the vast, vast majority of those cases, what we found is they had bipolar symptoms, maybe not the full disorder, but they had prominent dysregulation, they had some manic-like symptoms that preceded an event, a traumatic event that we think may have been caused by these bipolar symptoms that then catapulted into PTSD. And at the same time, you see worsening of the bipolar. Now, did the PTSD make the bipolar worse, or was the bipolar just naturalistically getting worse? To be honest, we don't know that. So it's a bit complicated, but in general, we see the bipolar driving more of the trauma than the trauma driving the bipolar. What are the potential long-term consequences of misdiagnosis or delayed diagnosis of juvenile bipolar disorder in a child, let's say, who starts with symptoms of ADHD, and how can these be mitigated? So anytime you delay on the diagnosis and treatment of a child disorder, you're subjecting that child to living with the disorder, which puts them at risk, in terms of academics, socially, risks of high risk, especially as they enter periods of time where they can get into trouble with high-risk behaviors, including everything from riding your bicycle to then doing driving cars, getting involved with juvenile justice, things like that. And that all tends to increase with lack of treatment. Another one that I've been very involved with is looking at substance use disorders. In juvenile bipolar disorder, in its untreated state, 65% will develop a substance use disorder. The studies, the signals we're getting from at least two studies, one study we did, one study from the Kobe, would indicate that treatment of bipolarity in kids helps to mitigate the risk for, let's say, substance use disorders, which is a good outcome. Other studies have shown reductions in the risk for things such as suicide, overdoses, and other things that we think are a result of untreated bipolar. And finally, I'll just say the longer you leave juvenile disorders untreated, the more symptoms you're going to have, the more sort of additional sequelae that may not have been there had you treated the disorder. And we see that for virtually all psychiatric disorders in childhood. Would you consider retrying a stimulant that previously caused irritability without mood stabilization after mood has been stabilized in a child with bipolar? Great question. The answer is yes. I've done it personally many times when we've been treating somebody or somebody else treated. There was sort of an activation, really getting losing it, dysphoria. We stabilize the mania, and then we go back. Now, would that be my first choice? For a couple of reasons, not. One, because I'm still a bit nervous about it. Parents are certainly nervous about it, and kid is nervous about it. And given that there's so many different preparations of methylphenidate and amphetamine, or you can switch, classes, I might do that first. But would I go back and try something? Yes. How long would I wait? I would wait until they're stabilized. And we have data that show, very old data, but data that would show that if the kid didn't get better or if they had worsening and then you stabilize the mania, same treatment, they do better. So there is data to support it. It's older data, but it's a great question. What red flags have you seen when an antidepressant is introduced to someone who has been diagnosed incorrectly, let's say with MDD, who is actually bipolar? And the biggest thing you'll see is medication-induced hypomania. And what that is not long after you give the medication, what you'll see is problems with mood lability, worsened mood, rage attacks, agitation, dysregulation, severe irritability. And then you'll actually see manic-like symptoms. They're not sleepy, not tired the next day. They have lots of activities that are goal-directed activities that are really kind of irrelevant to whatever its context is, perseveration, and things like that. Now, we found something very interesting, which is one of the questions that comes up frequently is, so if somebody has a reaction to an antidepressant, let's call it a disinhibition reaction. You start it and they start acting a little bit differently, or their sleep is off, or they get irritable. Does that mean they have bipolar? Well, actually, we did a study of that a long time ago, and what we found was that if the activation occurred pretty quickly after you started the medicine, no, it could have just been a reaction to the antidepressant. It could have been a non-specific reaction. But if it started later, and what do I mean by later is after 90 days, we found that if you see that kind of a reaction to an antidepressant, that often means that there could be manic episode. And what bipolar mavens will tell you is what they often see in referrals is that, rightfully so, people say, well, there's more mood here because we're seeing irritability, we're going to go up on the antidepressant. And then you see more agitation, more irritability. Well, we need to even go higher. And so you start to create the cycle because you're trying to treat something and you haven't realized that what you're actually seeing is a lot of mood dysregulation just because of the antidepressant. Again, if it starts right away, no, it actually doesn't necessarily mean you have a predisposition to mania or anything. And by the way, if you stop it, it tends to get better. But if it starts after you've been treating somebody for a while, it, first of all, doesn't go away right away when you stop the antidepressant, but you really need to think about that. So as you do antidepressant increases in kids with MDD, if you start to think about, I'm going up and they're almost getting worse, and I'm going up and they're almost getting worse, maybe they are getting worse, and maybe it's time to think about, is the medicine causing that, or diagnostically, is something else emerging? Remember, we're treating people when disorders emerge. It could be that the mania is starting to peak through, and the antidepressant is just making it, lowering the threshold so you see it sooner. So question is, why switch to short-acting stimulants in ADHD bipolar patients? Risk for rebound. Yeah, we've been teaching the field to do really well by using extended release, and I think for ADHD in general, we like the extended release. So I just want to be out there saying, treat a lot of ADHD like extended release for a million reasons. But for those kids who have bipolar where you use an extended release and they seem to dysregulate with the stimulant, before you say, I'm not going to use a stimulant, or I want to give up on, let's say, methylphenidate, before you do that, think about, maybe I'm going to change it from a 12-hour preparation to a 6-hour preparation or a 4-hour preparation in immediate release, and give that a try and see if that works. Because what you find sometimes is the shorter acting has a little bit less mood lability in some cases than the extended release. It's a little counterintuitive because you would think the extended release. On the other hand, it makes sense in some ways because the extended release exposes the child to a higher dose of stimulant through the day, whereas the immediate release, you're doing more up and down, up and down, up and down. What about the risk for rebound? Yes, you're going to get more of that with the short acting. We go back to, you got to multiple times a day administer it. You got rebound on the other side. There's, for all the reasons I like extended release better, but for this population, yeah, you can start with an extended release, but think about a short acting if you're running into problems with the extended release. Do you still use bupropion? If so, short or extended release? I use a lot of bupropion. I like it for mood symptoms. It's not as good for MDD. It's been tested and it's not particularly effective in kids. I use it in adults. But it also helps ADHD. And there's older literature from studies we've done and other people have done that show that it seems to be okay when you have some mood lability with ADHD. What do we like, the shorter or extended? I almost always use the extended release. I like the extended length, the once a day preparation, because almost nobody takes the afternoon dose of bupropion. Or if they do, they often take it too late, and it can really keep people up at night. You probably know it looks very similar to amphetamine, which looks very similar to dopamine, by the way. And so it breaks down, and its metabolite can be very activating. So a once a day in the morning works well for all of the indications. What resources and tools are available to healthcare professionals to stay up to date with the best evidence treatment strategies for these two conditions to make informed decision-making? Yeah, that's a great point. I think more and more it's coming to conferences like NEI, going to CME conferences, anywhere, listening to people, going to the big conferences, the professional conferences like the American Academy of Child and Adolescent Psychiatry, where there's symposium that are dedicated to this comorbidity. It's trying to keep up with the literature. There's a lot of reduction of the literature. And then groups like CHAD, there are support groups like CHAD and BP Kids that actually have quite a bit for practitioners also. So you can take a look. But it's not like people are updating all the time on bipolar or ADHD comorbidity. It's kind of coming to conferences, reading what's in the literature, take a look at authors that you trust who have done work in this area and are informed, and they often have written textbooks that can also be pretty helpful.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.